causative factor neighboring structure whole chapter I summarize also. But before reading that table, you must remember the figure. Figure here पढ्यो भने सजिलो हुन्छ. So moving to local anesthesia and nerve blocks in maxillofacial region. So we'll discuss the introduction, definition of local anesthesia, classification of local anesthesia, chemistry, its mechanism of action, composition, role of vasoconstrictor in local anesthesia, types of nerve block in maxillofacial region, its complications, and complication of local anesthesia. If you see the structure of the nerve, it consists of single nerve fiber. Each nerve fiber, in the case of myelinated nerve fiber, it is covered by Schwann cell, and each nerve fiber is covered with endoneurium. And multiple nerve fiber consists of the bundle of nerve fiber forms the fascicle, and each fascicle is surrounded by perineurium. So innermost covering is endoneurium, the fascicle is covered by perineurium, and the bundle of fascicle is again covered by epineurium. So the epineurium is the outermost covering, perineurium is intermediate, and endoneurium covers the individual nerve fibers. So its significance is whenever we are giving the local anesthesia has to reach the nerve fiber. If you don't reach up to the individual nerve fiber, local anesthesia will not work. And especially in case of myelinated nerve fiber, local anesthesia usually acts in the region of nodes of Ranvier. The space which is present between the two Schwann cell, it is known as node of Ranvier. The local anesthesia usually acts in the region of node of Ranvier. Also during the generation of action potential, action potential is generated only at the region of node of Ranvier in case of myelinated nerve fiber. And most of the intense pain is transmitted through this myelinated nerve fiber. These are fast conducting nerve fiber. So the thing you have to understand is the innermost covering of the nerve fiber is known as endoneurium, intermediate covering of its fascicle is known as perineurium, and the outermost covering of nerve bundle is epineurium. Okay, so local anesthesia has to reach to individual nerve fibers, and local anesthesia acts on at the region of node of Ranvier. Node of Ranvier is present between two Schwann cells. The space which is present between the two Schwann cells in case of myelinated nerve fiber is known as node of Ranvier. Physiologically, action potential is also generated only at the node of Ranvier, so the local anesthesia has to act at those node of Ranvier. If you see the physiology of impulse propagation, normally what happens? The concentration of sodium is more in case of extracellular fluid, and intracellularly the concentration of sodium is less. In contrast, just opposite happens in case of potassium. The concentration of potassium is more intracellularly and it is less in extracellular fluid. If you see the concentration of potassium, it's about 110 to 170 millicalorie per liter in the intracellular fluid, and it is about 3 to 5 millicalorie per liter in case of ECF, extracellular fluid. Okay, so the ratio is about 27:1. But in case of sodium, its concentration in intracellular fluid is only 5 to 10 milliequivalent, and it is about 140 millicalorie per liter in case of extracellular fluid or in plasma. So the ratio is again 1:14. The important thing you have to understand is whenever you are doing the CBC, complete blood count, we are only aware of the its concentration in the extracellular fluid. That's why if you do the CBC of any patient, you will get the concentration of sodium or potassium which is present in the extracellular fluid. We never measure in the routine cases its concentration in the intracellular environment. So normally in extracellular fluid, the concentration of sodium varies from 135 to 145 milliequivalent per liter, and the concentration of potassium is only 3 to 5. If it's less than 3 or more than 5, it has severe effect on cardiac muscles. So there will be ECG changes. During impulse propagation, we exclusively discuss about the sodium and potassium. Only the sodium and potassium plays the major role in case of impulse propagation. What happens? The concentration of sodium is more in extracellular fluid, and it is relatively less in case of intracellular fluid. In contrast, the concentration of potassium is more in intracellularly and it is less in extracellular environment. Now, what happens in case of normal when the impulse is not generated, when the action potential is not generated? In that condition, the concentration of sodium is more in extracellular fluid and the concentration of potassium is more intracellularly in all the cells. The resting potential in normal condition, when the action potential is not generated, the voltage of intracellular environment is minus 70 millivolt. Okay. Now what happens in case of impulse propagation or generation of action potential? The concentration of sodium, which is more in extracellular fluid, which will enter into the intracellular fluid. Okay, intracellularly. Once the sodium which is present in the extracellular fluid enters into intracellular fluid, what happens? The sodium is positively charged. So the negative potential minus 70 millivolt, which is present in the normal condition, will increase to minus 65, minus 60, minus 55 accordingly. So once it reaches to minus 50 to minus 60 millivolt, then what happens? There is something called as voltage gated sodium channels. Once the threshold potential is reached, the threshold potential is minus 50 to minus 60 millivolt. Normal resting potential is minus 70. Once the sodium ion enters inside the intracellular fluid, the resting potential increases to minus 50 to minus 60 millivolt. It is known as threshold potential. Once the potential reaches to minus 50 or minus 60, then the other voltage gated sodium channels also gets open. Now what happens? The huge amount of sodium ion which is present in the extracellular fluid will enter into the intracellular fluid. Now again what happens? The membrane potential, which is about minus 50 to minus 60 millivolt, will rise to plus 40. It will rise to minus 40, minus 30, minus 20, minus 10, 0. Then it will enter into the positively plus 10, plus 20, plus 30. Once it reaches the plus 40, it is known as the cell is in depolarized state. And this depolarized, once the cell reaches into this depolarized state, it is said that the action potential is generated. Okay. Now what happens once the cell is depolarized, once the action potential is generated? The condition is, once the action potential is generated, now comes the role of potassium. What happens? The potassium channel gets opened, and the potassium which is present in the intracellular fluid will exit through the potassium channel, and it will enter into the extracellular fluid. So it will come out. If the ion gets inside the cells, it is known as influx, and just opposite, if any ion comes out of the cell, it is known as efflux. Influx and efflux. Okay, ion flux is influx. It is entering any ion inside the cell from the extracellular fluid, the intracellular fluid, that is known as influx of sodium ion. Efflux means EFFLUX. Efflux means movement of any ion from the intracellular fluid to the extracellular fluid. So here is efflux of potassium ion. The potassium ion will go out of the cell and it will enter into the intracellular external environment in extracellular fluid. So the action potential, which is plus 40, now will again decrease due to efflux of potassium ion. The potassium which is positively charged will go out of the intracellular environment. It will enter into the extracellular environment. So the potential which was plus 40 intracellularly will decrease again to plus 30, plus 20, plus 10, 0, and then again into minus 60 to minus 90 millivolt. Average is minus 70 millivolt. Again, after the action potential is generated, it has reached to the minus 70 millivolt, which is resting membrane potential. So the resting membrane potential minus 70, which is present, is reached. Now the problem is, normally what happens? The concentration of sodium should be more in the extracellular fluid, and the concentration of potassium should be more in the case of intracellular fluid. Now what happens in this condition? The scenario is just opposite. The sodium concentration is more in the intracellular fluid, and the concentration of potassium is more in extracellular fluid. Now that has to be managed. Now what happens? Once the action potential is generated, resting membrane potential is maintained. Now there comes the action of sodium potassium ATPase pump. So that sodium potassium ATPase pump, what it will do? It will take 3 sodium ion from the intracellular environment and take it out to the extracellular fluid, and it will take again 2 potassium ion from the extracellular fluid, and it will enter inside the intracellular fluid. So the sodium potassium ATPase will maintain the concentration gradient of sodium and potassium, and it is active pump. It is called active because the sodium potassium ATPase pump acts only by consuming the ATP, adenosine triphosphate. So it uses energy. That's why it is known as active pump, because the sodium, which is already the concentration of sodium more in case of extracellular fluid, so you have to, the sodium potassium ATPase pump has to act against the concentration gradient. That's why they consume energy and they transfer sodium ion from intracellular fluid to the extracellular environment, and in contrast, they take again potassium ion from the extracellular fluid to the intracellular fluid, and it maintains the normal resting potential of the nerve cells. Now, what is its significance in case of local anesthesia? Local anesthesia primarily acts on this nerve membrane. It basically blocks this mechanism. The local anesthesia do not allow the resting membrane potential to change, and the action potential is not generated. All the local anesthesia which uses, it blocks the sodium ion. As you know, the sodium ion is most important. It has to enter inside the cell for the generation of action potential. Once the local anesthesia block the sodium channel, the sodium ion can't enter inside the cell, and the action potential is not generated. Once the action potential is not generated, the impulse which is present in the periphery region will not reach to the brain, and the patient could not perceive, or the brain could not perceive pain. So the main aim of local anesthesia is to block this all mechanism. It primarily blocks the sodium ion, so the sodium ion could not enter inside the cells, and the resting membrane potential is not changed, and action potential is not generated. It blocks the normal physiology. So here you have to understand that the concentration of sodium is more in extracellular fluid, concentration of potassium is more in intracellular fluid. Action potential is generated due to influx of sodium ion. The resting membrane potential changes from minus 70 millivolt to plus 40 volt. Once it reaches to plus 40 volt, action potential generated. Again, after action potential generated, potassium channel is opened, and potassium will go out of the cell into the extracellular fluid. After that, again, it will reach to the resting membrane potential, and in order to maintain the normal concentration of sodium and potassium, it is taken up by sodium potassium ATPase pump. Sodium potassium ATPase pump will maintain the concentration gradient of sodium and potassium. Now moving to the definition of local anesthesia. According to Malamud, it is loss of sensation in a circumscribed area of the body caused by a depression of excitation in nerve endings or an inhibition of the conduction process in peripheral nerves. So ideal properties of local anesthesia are: it should not be irritating to tissue, it should not cause permanent alteration of nerve structure, systemic toxicity should be low, effective whether injected or applied topically, time of onset of local anesthesia should be as short as possible, duration of action must be long enough to complete the procedure but not so long as to require extended recovery, it should be stable in solution, easily biotransformed, should not cause allergic reaction, and should be sterile or capable of being sterilized by use of heat. But unfortunately, none of the local anesthesia has all these ideal properties. Moving to classification, types of local anesthesia, basically it was classified into two types, esters and amides, and new one is quinolin. Okay. The esters are again of two types, esters of benzoic acid and esters of parabenzoic acid. Esters of benzoic acids are butane, cocaine, ethylamine benzoate, or it is also known as commonly benzocaine. Benzocaine is available as topical anesthesia. Okay. Next is hexylcaine, piperocaine, tetracaine. Esters of para-aminobenzoic acid are chloroprocaine, procaine, propoxycaine. The problem with esters local anesthesia is they produce more allergic reaction. That's why they are not used. And we commonly use amides. Comparatively, amides produce less allergic reaction as compared to esters. The examples of amides are articaine, bupivacaine, dibucaine, etidocaine, lidocaine, mepivacaine, trilocaine, and ropivacaine. And the new one is quinolin, that is centbutridine. If the patient is allergic to both esters and amide, then you can use centbutridine. Now there is one formula to remember whether the local anesthesia is amide or ester. In case of all the amides, there are two I. If amides contains of I plus cane, in all the name, you can see there are two I plus cane. In case of esters, there is only one I, only cane, except piperocaine. Okay. Though you have to remember or know all these names, commonly we use only lignocaine and bupivacaine. Bupivacaine is long-acting local anesthetics, so you use generally during major surgery. Even after giving general anesthesia, we give the infiltration through using bupivacaine because it is long-acting. And in case of all the minor surgical procedure, we exclusively use lidocaine. Sometimes we use benzocaine as topical anesthesia, but nowadays lidocaine is also available in form of gel or ointment and a spray. So for topical anesthesia, we can use lidocaine. Under classification based on potency and duration. If there is low potency and short duration, it acts only for 30 minutes. Example are procaine and chloroprocaine. Intermediate potency and duration, its duration of action is for 60 minutes in pulp. Example are lidocaine and pilocaine. And there is high potency and long duration, it works for more than 90 minutes. They are tetracaine, bupivacaine, and divacaine. If you see the metabolism of local anesthesia, what happens is whenever you inject a local anesthesia near the nerve membrane, it will enter into the blood. From the blood, it will circulate all over the body. In the body, as you know, all the organs do not get the same amount of blood supply. Okay, the brain, myocardium, lungs, liver get the largest amount of blood, and the local anesthesia which we inject will easily enter into these organs, and it will reach to the equilibrium state rapidly. In contrast, the fat and muscle cell get very less amount of blood, and also local anesthesia which we inject into the body will reach to this area very slowly, and again once it is reached there, it is again excreted in the blood after a long time. So it will reach in equilibrium after long time. It will take long duration to reach the equilibrium in fat and muscle. So it is known as slow equilibrium space. In the organ which has abundant amount of blood supply, like brain, myocardium, lungs, liver, it will reach to the equilibrium state very fast. So those spaces are known as rapid equilibrium space. Finally, once it reaches to those organ, again it will be excreted back to the blood and will be eliminated mostly through the urine. It is excreted through the urine. Okay. In case of Pistor's local anesthesia, it is metabolized primarily by plasma pseudocholinesterase. This enzyme is very important. Usually they ask the question. Esters are metabolized by plasma cholinesterase. Its byproduct is PAVA. It is para-aminobenzoic acid, which is responsible for allergic reaction. This statement is very important. They have asked the enzyme which is used to metabolize the ester local anesthesia, that is plasma pseudocholinesterase. Its byproduct is PAVA, para-aminobenzoic acid. Para-aminobenzoic acid is primarily responsible for allergic reaction, and due to this allergic reaction, esters are not preferred as local anesthetic agent. Only we have to study the theory. Practical, we never use ester. In case of amide, it is metabolized in liver, and there is low risk of allergic reaction. All the amide local anesthesia, lidocaine, bupivacaine are metabolized in the liver, and the chances of allergic reaction is very low. Mechanism of action. Nerve membrane is the primary site of local anesthetic action. There are 5 theories to explain the mechanism of action of local anesthesia. Among them, only a specific receptor theory is widely accepted. And that is membrane expansion theory. It explains the mechanism of action of benzocaine. Other 3 theories are not accepted. Only you have to know the name. The theories are acetylcholine theory, calcium displacement theory, surface charge theory, membrane expansion theory, and specific receptor theory. Only a specific receptor theory is widely accepted, and it explains the mechanism of action of local anesthetic agent. Acetylcholine theory states that acetylcholine was involved in nerve conduction as it acts as a neurotransmitter at nerve synapses, but no evidence found in acetylcholine involvement. That's why this theory was rejected. Another theory was calcium displacement theory. It stated that the local anesthetic nerve block was produced by displacement of calcium from membrane side that controlled membrane permeability to sodium. Again, it was not proven, and that's why it was also rejected. The third one is surface charge theory. It stated that the local anesthetic acted by binding to the nerve membrane and changing the electric potential at membrane surfaces, but no evidence suggests that there is change in surface charge. That's why this theory was also rejected. So only you should know the name. You don't have to go into detail. Next one is membrane expansion theory. This membrane expansion theory explains the mechanism of action of benzocaine only. According to this theory, what it says, the local anesthetic like benzocaine will enter into the lipid membrane. Once it enters into the lipid membrane, as you know, all the membrane are made up of phospholipids, and phospholipids are only lipid soluble molecule can enter into the lipid membrane. It can cross the lipid membrane. So the local anesthetic like benzocaine will enter into the phospholipid lipid membrane. Once it enters into the lipid membrane, what it causes? it causes the expansion of this lipid membrane. And as you know, for generation of action potential, sodium ion has to enter inside the cell. So what it causes? It blocks the sodium ion channel. This is the sodium channel. Once the benzocaine enters into the lipid membrane, this lipid membrane causes expansion of this lipid phospholipid layer. This, due to expansion of this phospholipid layer, it will block the voltage gated sodium channel. Once the sodium channel is blocked, the sodium could not enter inside the cell. That's why the nerve will not be depolarized and the action potential will not be generated. Okay. The basic thing is the local anesthetic like benzocaine, which is not polarized. It is a neutral molecule, will enter into the lipid membrane. Once it enters the lipid membrane adjacent to the sodium channel, it blocks the sodium channel, so the sodium ion could not enter inside the cell. The depolarization will not take place, and there will be no generation of action potential, and the impulse will not be conducted through that nerve. Next is a specific receptor theory. What it states is, whenever we deposit local anesthesia adjacent to the nerve cells, what will happen? This is a local anesthetic agent, RNS plus. R is the alkyl group, S plus H is a hydrogen ion, okay, N is a nitrogen. So what happens whenever we deposit a local anesthesia near the nerve membrane, it is a reversible reaction. It will dissociate into Rn and S plus. R is the alkyl group, N is a nitrogen, S plus is a hydrogen ion. So once it dissociates into Rn and S plus, it will enter into equilibrium state. It is a reversible reaction. The reversible reaction means if the concentration of reactant is high, then it will proceed to forward reaction. If the concentration of product is high, it will again favors reverse reaction. So they are in equilibrium state. Now what happens? Once the local anesthesia is deposited near the nerve cells, it will dissociate into Rn and S plus. And as you know, all the nerve membrane are, or all the membranes are made up of phospholipid. So only the ion or the molecule which is unionized will enter inside the cell, because the ionized molecule could not enter the membrane. So only molecule which are unionized will enter inside the intracellular fluid. So only Rn molecule will enter inside the cell or in intracellular compartment. Once it enters into the intracellular compartment, again this R1 will react with S plus ion and it will form the RNH plus ion. Again, it is equilibrium reaction. It's the same reaction, okay? So within the nerve cell inside the intracellular cavity, the Rn react with the S plus ion, it will form the RNH plus. This RNH plus will bind to the voltage gated sodium channel. Once it binds the sodium channel, it blocks the sodium channels, okay? So the sodium ion could not enter from extracellular fluid to into the intracellular fluid, so there will be no depolarization, no action potential will be generated, and it will lead to blockage of conduction of pain impulses from the peripheral nerve to the brain. So patient will not have any sensation of pain. It's very simple. Whenever you deposit a local anesthesia near the nerve cells, it will dissociate into Rn and S plus ion. Rn, which is neutral molecule, will cross the lipid membrane, will cross the lipid membrane, and it will reach to the intracellular fluid. Within the intracellular fluid, it will react with the H plus ion, and it forms the RNH plus. This RNH plus will bind to the voltage gated sodium channel, and in voltage gated sodium channel, once it binds to the voltage gated sodium channel, it blocks the sodium channels, so the sodium ion can't enter from the extracellular fluid to the intracellular fluid. So there will be no depolarization. There will not be any action potential generation. Once the action potential is not generated, the impulse could not be conducted from the peripheral nerve to the brain. That's the basic mechanism of local anesthesia. It primarily blocks the voltage gated sodium ion. So specific receptor theory, it is most widely accepted theory. It states that local anesthesia act by binding to a specific receptor on sodium channel. Okay, so local anesthetic binds with a protein of sodium channel at inactivated stage. It blocks the voltage gated sodium conductance or sodium influx. It blocks the depolarization, so fail to initiation and propagation of action potential. Nociceptive impulses can't go to higher center, and patient will have no pain. That's the basic mechanism. It's same mode of action. Okay, in case of extracellular fluid, its pH is 7.4. It varies from 7.35 to 7.5. 0.45. That is normal pH of blood. Let's say if you deposit 1000 molecule of RNH plus, then what will happen? The RNH plus will dissociate it into RN and H plus ion. H plus ion is not shown here because, as you know, hydrogen and hydroxyl ion is present everywhere, because the water, which is H2O, is always in equilibrium state. It forms H plus ion and hydroxyl ion. H2O breaks down into H plus ion and hydroxyl ion, and they are in equilibrium state. So H plus ion, OH minus ion, H2O is present everywhere. That's why the H plus ion is not shown here. So the RNH plus will dissociate into Rn and S plus. Let's say if you have deposited about 1000 molecule of local anesthesia, among them 750 will be in the form of RNH plus and 250 will dissociate into Rn form. Once this unionized molecule enters inside the cells, it crosses the lipid membrane, the nerve sheath membrane, then it will enter into the intracellular fluid. Again, it will dissociate into, or it will form, it reacts with S plus ion and form RNH plus ion. So among 250 molecule, 70 will be in the form of Rn, and only 180 molecule it forms the RNH plus ion. This RNH plus will bind to the voltage gated sodium channel, it blocks the sodium influx, and the depolarization will be not be there. So action potential will not be generated, and there will be no conduction of impulses. Out of 1000 molecules, 750 molecule is in the form of RNH plus ion, 250 molecule is in form of Rn. This unionized 250 molecule will enter inside the cell. It will be in equilibrium state, react with S plus ion, and it will form the equilibrium with RNH plus ion. Among 250 molecule, 180 will form RNH plus, and only 70 molecule is in the form of Rn. This ionized molecule RNH plus will react with, or it binds to voltage gated sodium channel. It blocks the sodium channel, and the influx of sodium ion is prevented. That's why the nerve will not be depolarized, action potential will not be generated. Once the action potential is not generated, the impulse which is present in the peripheral nerves will not be reached to the brain, and there will be no pain. That's basic mechanism. Now the important question, you have to know it both in case of practical scenario as well as it is asked many times in the exam. What is the effect of low pH, especially in case of infection? It is said that if there is a presence of infection, local anesthesia will not work. If pH is low, the local anesthesia doesn't work. But why? The reason is low pH means the concentration of H plus ion is high, right? Low pH means the concentration of H plus ion is high. It is acidic environment. High pH means it is alkaline environment. Low concentration of H plus ion is low. Concentration of hydroxyl ion OH minus is more. In case of acidic environment, concentration of H plus ion is more. That's why what happens whenever, let's say again, if you have deposited 1000 molecule of RNH plus ion, 990 molecule will be in the form of RNH plus, only 10 molecule will dissociate into Rn. Because what happens, as you know, in case of reversible reaction, in case of acidic environment, the concentration of H plus ion is very high. So when your RNH plus will dissociate into Rn and H plus ion, as the concentration of product is more, the concentration of H plus ion is more, the reverse reaction is favored, and the more amount of molecule will be present in undissociated form. It will be present in the form of RNH plus ion, because the concentration of H plus ion is very high in case of extracellular fluid. In case of low pH, in case of infection, the concentration of H plus ion is very high. Due to the presence of more amount of H plus ion, the local anesthetic molecule will not dissociate. So what happens in this condition? If you remember the previous slide, about 250 molecule was dissociated into Rn, but here only 10 molecule has dissociated into Rn. Now among those 10, this 10 will enter inside the intracellular fluid. It crosses the lipid membrane, and it will react with again H plus ion, and it forms the RNH plus. Now what happens? This Rn, among those 10 molecule, 7.5 molecule will form RNH plus ion, and only 2.5 will form Rn. Now this 7.5 number of RNH plus molecule will react with it binds to the voltage gated sodium ion, and it blocks the sodium channel. Previously 180 molecule was there to bind the sodium channel, but in case of acidic environment, if you compare, only 7.5 molecule will bind to the sodium channel. That's why the sufficient number of voltage gated sodium channel are not blocked, and it could not prevent the generation of action potential or depolarization, and the still patient will have some pain. That's why in case of acidic environment, if there is infection, the local anesthesia has less effect. It will not work. It is due to presence of more amount of H plus ion. Due to presence of more amount of H plus ion, local anesthesia could not dissociate, and it could not block the sufficient number of voltage-gated sodium channel. Once the sufficient number of voltage-gated sodium channel is not blocked, still there is influx of sodium ion, and it will lead to generation of action potential, and the impulse will be conducted from peripheral nerves to the central nervous system, and the patient still feels pain. Another important thing, you must remember that in case of space infection, local anesthesia will not work if you inject a local anesthesia within the infection, near the infected area. Suppose if there is, let's say, vestibular space infection in the region of canine or premolar region. Okay, if you deposit the local anesthesia, if you give the local infiltration in the canine or premolar area, let's say it's lower canine premolar area, it will not work. But if you give the nerve block, definitely it will work. So the local anesthesia is not effective in case of acidic environment, in case of infection. If you deposit the local anesthesia within the infection, near the infection, then only it will not work. But still you can give the nerve block, because there is no any problem in the pterygomandibular space. In the pterygomandibular space, if you deposit the local anesthesia, definitely it will work. So it is also asked many times. You should also know these things when you are treating the patients practically. In case of infection, the local anesthesia will not work, especially if in case of space infection, if you give a local infiltration, it may not work due to presence of acidic environment, due to presence of more amount of H plus ion. The local anesthesia could not block the sodium channel. Still there is conductance of sodium ion, influx of sodium ion. It will lead to generation of action potential. So the reason is, in case of infection, in case of acidic environment, the concentration of H plus ion is more. Due to the presence of more amount of H plus ion, the local anesthesia could not dissociate. Once the local anesthesia is not dissociated, it could not block the sufficient number of voltage-gated sodium channels, and the sodium influx is not prevented. Next thing is, you should know is core fibers and mantle fibers. Okay. If you see the nerve bundle, as you have seen, the individual nerve fibers, the bundle of nerve fiber forms the fascicles, and the multiple fascicle forms the nerve bundle. If you see the nerve bundle, there is presence of some are present in the center, some nerve fibers are present in the periphery. The nerve fibers which are present in the center are known as core fibers, and the nerve fiber which are present in the peripheral region is known as mantle fiber, peripheral fiber. So what happens whenever you deposit the local anesthesia? We deposit local anesthesia around the nerve fiber, right? So when you deposit the local anesthesia near the nerve fiber, what will happen? The nerve which are present in the peripheral region, the mantle fiber will get the sufficient amount of local anesthetic solution, and they will be anesthetized. The local anesthesia can block the voltage-gated sodium channel, and it blocks the conduction of impulse from the peripheral nerve to the central nervous system. As you compare to the core fiber, the sufficient amount of local anesthetic solution could not reach to the center. The nerve which is present in the periphery will get the sufficient amount of local anesthesia, and the nerve which is present in the central region will not get the sufficient amount of local anesthetic solution though. So what happens? The nerve which are present in the periphery region will be blocked, and the nerve fiber which is present in the central region will not be blocked. So it is due to the presence of mantle fiber and core fiber in the same nerve bundle. In the same bundle, the nerve which are present in the center will not be anesthetized, and the nerve which is present in the peripheral will get anesthetized. The clinical implication is, whenever you are giving the inferior nerve block, the nerve which are present in the periphery, it supplies the molar tooth, and the nerve which are present in the center which supplies to the anterior tooth. So practically, it is possible that if you give the inferior nerve block, there will be anesthesia over the molar tooth, but there will be still pain if you do any procedure in the anterior region. It is due to presence of core fiber and mantle fibers. Okay. So the nerve fiber which are supplied by the peripheral nerves will be sufficiently anesthetized, and the structure which are supplied by the core fibers will not be anesthetized. If you see the composition of local anesthesia, it consists of local anesthetic agent like lidocaine, hydrochloride. Its function is to block the nerve conduction. It also consists of sodium chloride. It maintains the isotonicity of the solution. The isotonicity of the plasma and local anesthetic solution is same. It also consists of sterile water. It maintains the volume. Also, it consists of adrenaline, vasopressor, increases the depth and duration of anesthesia. Basically, it causes vasoconstriction. So due to vasoconstriction, it increases the depth and duration of anesthesia, decreases absorption of local anesthetic and vasopressor. It also consists of sodium metabisulfite. It acts as an antioxidant, and there is methylparaben, which is bacteriostatic agent. You must remember this composition. The local anesthetic consists of these 6 items. In case of plain local anesthetic, the vasopressor is not there. Rest, everything is same. Duration of local anesthesia. If you see the duration of local anesthesia, whether the concentration of adrenaline is 1:50,000 or 1:1 lakh, it doesn't matter. Duration of anesthesia remains same. That's why it is said that always try to use anesthesia which is more dilute. So it's always better to use glucosamine with adrenaline at concentration of 1:2 lakh, because even though if you use the concentration of vasoconstrictor as 1:50,000, the duration of action doesn't change. In pulp tissue, it works for 60 minutes, and in case of soft tissue, it works for 3 to 5 hours, 180 to 300 minutes. So in our country, we get the local anesthesia in the concentration of 1:80,000, 1:1 lakh, 1:2 lakh. So preferably, you always should use 1:2 lakh, because the more dilute solution you use, the chances of complication is less. Maximum recommended dose is, again, with adrenaline is 7 mg per kg, without adrenaline is 4.4 mg per kg. But you should not cross 500 mg with adrenaline and 300 mg without adrenaline, that is plain anesthesia. With adrenaline, or it is also known as epinephrine, it is commonly used in dentistry in local anesthetic solution as well as life-saving drug in anaphylaxis. Now the question is, it can be used in case of an anaphylactic shock. In case of anaphylaxis, can you use the same adrenaline which is present in the local anesthetic vial or not? Even though both are adrenaline is present in local anesthetic vial as well. Can you use those adrenaline which is present in local anesthetic vial during anaphylactic shock? And it is emergency condition. And in anaphylactic shock or in case of anaphylaxis, you have to treat the patient immediately. The problem is, in oral surgery, there are many topics, and it's very difficult to cover all the topics within 10 days. Still, many things are left. So even though the adrenaline is used in case of anaphylactic shock, in case of emergency, you can't use the same adrenaline which is present in local anesthetic vial, because in case of anaphylactic shock, you have to use the adrenaline in the concentration of 1:1000. That is present in a vial you can get in the market, that is 1 ml vial, and the concentration of adrenaline is 1:1000, and that is injected subcutaneously. Can inject गर्ने? In the interlateral part of thigh, there is vastus lateralis muscle. Intramuscular दिन सकिन्छ. Anterolateral part of thigh, in the vastus lateralis muscle, you can inject 0.5 ml of adrenaline in the concentration of 1:1000. The adrenaline which is present in our local anesthetic vial is in the concentration of, it is in dilute condition, 1:80,000 or 1:2 lakh. As well as there is not only adrenaline, there are other drugs as well. So you can't use such adrenaline which is present in local anesthetic vial in case of anaphylactic shock or in case of emergency condition. Mechanism of action of low adrenaline is it interacts with adrenergic receptor in the vessels, alpha and alpha 2 producing vasoconstriction in skin and mucous membrane. Beta 2 stimulation causes vasodilation in skeletal muscle and bronchodilation. So it depends on which receptor it acts. There is alpha 1 receptor, alpha 2 receptor, beta 1 receptor, beta 2 receptor. Alpha 1 receptors are present in peripheral vasculature. It causes vasoconstriction. Beta 1 receptors are present in heart. It causes tachycardia, increases heartbeat. Beta 2 receptors are present in large blood vessels, skeletal muscles, and liver. It causes again vasodilation. Also, beta 2 receptors are present in bronchioles. It causes bronchodilation. So, in case of asthma, we use salbutamol. The purpose of that drug is to act on beta 2 receptor, and that causes bronchodilation. Metabolism, it appears very rapidly in the systemic circulation. It is exogenously administered. Epinephrine is metabolized extraneuronal, and 1% is excreted in the urine on stage form. About 99% of them are metabolized in the liver and are excreted in the urine. Dosages, concentration of vasoconstrictor need to be between 1:8,000 and 1:2 lakh to improve the duration of action. Now the dose of adrenaline. If the concentration is 1:1,000, the dose is about 1 mg per ml. You have to calculate the dose of adrenaline as well. While injecting the local anesthesia, you have to calculate the dose of lignocaine as well as you have to calculate the dose of adrenaline. For adrenaline, dose is 0.2 mg for normal healthy patient and 0.04 mg for cardiac patient. You should not cross this dose. You should not give more than 0.2 mg of adrenaline in normal healthy patient and 0.04 mg in case of cardiac patients. So if the concentration is 1:1 lakh, then its dose is about 0.01 mg per ml. It indicates that in 1 ml of local anesthetic solution, there is 0.01 mg of adrenaline. So how will you calculate the dose of adrenaline? 1:1000 means 1 gram of adrenaline is present in 1000 ml of solution. 1:1000 means 1 gram of adrenaline is present in 1000 ml of solution. If you convert gram into mg, then it is 1000 mg of adrenaline is present in 1000 ml of solution. So if you cancel all 30 from both the side, it is 1 mg of adrenaline is present in 1 ml of local anesthetic solution. So usually we use 1:80,000, 1:1 lakh, or 1:2 lakh concentration of adrenaline in local anesthetic vials. So 1:1 lakh means 1 gram of adrenaline is present in 1 lakh ml of solution. If you convert gram into mg, it is 1000 mg of adrenaline is present in 1 lakh ml of solution. So if you cancel the 30, then 1 mg is present in 100 ml of solution. So 1 ml consists of 1 by 100 mg. 1 by 100 mg is 0.01 mg. 0.01 mg of adrenaline is present in 1 ml of local anesthetic solution. It is simple unitary method. You have to calculate it. Whenever you are injecting local anesthesia, you have to calculate the dose of lignocaine as well as you have to calculate the dose of adrenaline. It is important both when you are treating the patient practically as well as it is asked in the exam. So 1:1000 means 1000 mg of solute contained in 1000 ml of solution. So 1000 ml of solution consists of 1000 mg of adrenaline. 1 ml consists of 1000 by 1000, that is 1 mg of adrenaline. Similarly, 1:2 lakh means 2 lakh ml of solution consists of 1 gram of adrenaline. If you convert gram into mg, it is 1000 mg of adrenaline. So 1 ml solution consists of 1000 by 2 lakh mg, that is 0.005 mg of adrenaline is present in 1 ml of local anesthetic solution. If your local anesthetic solution consists of adrenaline in the dilution of 1:2 lakh, then it consists of 1 ml of local anesthesia consists of 0.005 mg of adrenaline. And in exam, they ask such question: if the concentration of adrenaline in a local anesthetic vial is 1:2 lakh, then 1 ml of local anesthetic solution contains how much mg of adrenaline? The option will be 0.5, 0.05, 0.005, 0.0005. It's very confusing, so you have to calculate it. What is the role of vasoconstrictor? Addition of vasoconstrictor, it causes constriction of blood vessels, which decreases tissue perfusion. Also there is slow absorption into cardiovascular system. Low anesthetic blood level will lead to low risk of toxicity. Also, higher volume local anesthesia around the nerve, which increases the duration of action of local anesthesia. Also, the bleeding, it will decrease the bleeding at the injection site. The systemic effect, adrenergic system, which consists of two types of receptor, alpha and beta receptor. Again, alpha receptor is of two types, alpha 1 and alpha 2. Beta receptor is also of two types, beta 1 and beta 2. So beta 1 receptor is present in heart. It causes tachycardia, increases heart rate. Beta 2 receptor are present in vascular beds of the skeletal muscle and pulmonary vasculature. In skeletal muscle, it causes vasodilation, and in pulmonary vasculature, it causes bronchodilation. Also, alpha 1 receptors are present in peripheral vasculature. It causes vasoconstriction. Our primary role in case while injecting local anesthesia for infiltration is also to decrease the bleeding. Peripheral vasculature, it causes vasoconstriction. So the absorption of local anesthesia is decreased, duration of action is increased. So we primarily use local anesthesia with adrenaline. Our main purpose is to let the adrenaline action alpha 1 receptor, which are present in peripheral vasculature, and alpha 2 receptors are present in CNS. Most of you have seen the patient who get syncope attack during dental treatment, especially during extraction. What is the mechanism behind that syncope? It's associated with these receptors, and that is syncope is related to these receptors. That's why I asked you. What is the mechanism? Syncope किन हुन्छ? Mechanism के हो? Okay, online अनुभवको डाक्टर साहबहरु, what is the mechanism behind syncope? How it happens? What is the mechanism? Why it happens? In our body, what happens? Basically, there are two systems: sympathetic nervous system and parasympathetic nervous system. Right? Parasympathetic is used during rest and digest. All the gastrointestinal tract is controlled by parasympathetic system. Salivary gland secretion, gastric acid secretion, pancreatic secretion, all are controlled by the parasympathetic nervous system. And sympathetic nervous system is for fight and flight. Whenever you are ready for fight and flight, the sympathetic nervous system gets activated. So what happens when the patients are in fear? Okay, in that condition, the sympathetic nervous system gets activated. When the patient is in more fear, the sympathetic nervous system will get activated. Then what happens? When the sympathetic nervous system is activated, there will be rush of adrenaline secretion. More amount of adrenaline is secreted in the blood. So this adrenaline, what causes this adrenaline? It will act on beta 2 receptor in the skeletal muscle. At low concentration in the periphery, it acts on the peripheral vasculature. In the alpha 1 receptor, it causes vasoconstriction. But if the concentration of adrenaline is very high, it acts on skeletal muscle. Skeletal muscles consist of beta 2 receptors. So these beta 2 receptor, when the adrenaline acts on these beta 2 receptor, it causes vasodilation. Once there is vasodilation in the skeletal muscle, what it causes is it causes pooling of blood. So due to pooling of blood, there will be insufficient blood circulation in the brain, because almost all of the blood will get pooled in the skeletal muscle. So in systemic circulation, very less amount of blood is present, which is not sufficient to maintain the cerebral circulation. So the blood supply to the brain is decreased, and patient will have syncope attack. Okay. So how will you treat them? It's easy. As you know, there is blood supply to the brain is decreased due to pooling of blood in the peripheral vasculature in the skeletal muscle. Just change the position. Okay. put head down, lift the leg, what happens? All the bloods which are present in the skeletal muscle of lower limb will be diverted to the brain, and patient will again regain the consciousness. So it is basically due to activation of sympathetic nervous system, and usually it happens in those patients who are in fear. During fear, the sympathetic nervous system will be activated. Due to activation of sympathetic nervous system, there will be rush of adrenaline. Those adrenaline acts on the beta-2 receptor of the skeletal muscle in the body. Due to this beta-2 receptor in the skeletal muscle, it causes pooling of blood. Due to pooling of blood in the lower limbs and the skeletal muscle, blood supply to the brain is decreased. Blood in the systemic circulation is less. So the blood supply to the brain is decreased. It will lead to syncope attack. Patient will lose the consciousness. Once patient has lost the consciousness, and also other clue how you know whether the patient is in syncope is due to activation of sympathetic nervous system. There will be sweating. If you see the forehead of the patient will be sweating. Also, there will be tachycardia due to the action of adrenaline in the heart. There will be also tachycardia. There will be sweating in the forehead area. Those are the pre-syncope attack. Once the patient has lost the consciousness, just change the position of the chair, lift the lower limb. All the blood which is pulled in the skeletal muscle will be diverted into the brain, and they will get the consciousness. Clinical aspect: the maximum dose of lignocaine without adrenaline is 300 mg. Maximum dose of lignocaine with adrenaline is 500 mg. If you see mg per kg, with adrenaline is 7 mg per kg, and without adrenaline is 4.4 mg per kg. So maximum safe dose of adrenaline is 0.2 mg per visit in case of normal healthy patient, and it is 0.04 mg in case of cardiac patients. So 2% lignocaine means 2 gram of lignocaine is present in 100 ml of solution. Okay. If you convert the gram into mg, it is 2000 mg. Percent always comes in case of percent. When you are using unitary method, you have to convert the percent into 100. Always percent is calculated in 100. 2% means 2 gram is present in 100 ml of solution. Once you convert the gram into mg, 2 gram is equivalent to 2000 mg. So 2000 mg of lignocaine is present in 100 ml of solution. So 20 mg is present in 1 ml of solution. 1 ml of solution consists of 2000 mg divided by 100, that is 20 mg. So 20 mg of lignocaine is present in 1 ml of solution. So 1 mg is present in 1 by 20 ml. It's simple unitary method. So 500 mg will be present in 1 by 20 into 500, that is 25 ml, can be given safely for a normal patient. This is according to dose of lignocaine. Again, you have to calculate the dose of adrenaline as well. Adrenaline is present in our vial is in concentration of 1:2 lakh. So 1 ml consists of 1 by 2 lakh or 0.005 mg of adrenaline. So 1 ml of local anesthesia consists of 0.005 mg of adrenaline. As maximum recommended dose is 0.2 mg. So far, normal patient 0.2 mg is present in 1 by 0.005 into 0.2, that is 40 ml of local anesthesia can be administered safely. So according to dose of adrenaline, it is 40 ml is safe. According to the dose of lignocaine, it is 25 ml is safe. So which one is less? We have to consider that. So in this condition, if the concentration is 1:2 lakh, you can give about 25 ml of local anesthetics with adrenaline safely. Okay. Dose is 1:2 lakh. That's why you can inject up to 40 ml. If the concentration is 1:1 lakh, then what will happen? Only you can give only 20 ml of local anesthetic solution. If dose is 1:80,000, I think it's about 16 ml. So if the concentration of adrenaline is 1:80,000, and if you are using 2% lignocaine, then according to dose of lignocaine, it is 25 ml, and according to dose of adrenaline, it will be only 16 ml. So in that condition, you can use only 16 ml of lignocaine. You can only inject 16 ml of local anesthesia with adrenaline safely in that patient. So it's better to use always dilute solution, 1:2 lakh. Another thing, it will be easy to remember for you. Always we use 2% lignocaine. 2% lignocaine means just place 1 0 and it will be 20. So 1 ml of lignocaine always contains 20 mg of 1 ml of solution contains 20 mg of lignocaine. Okay. Always we use 2% lignocaine. Just put 10, make it 20. So 1 ml of lignocaine contains 1 ml of solution contains 20 mg of lignocaine. It will be easy to calculate. Or if you use unitary method, 2 gram is present in 100 ml. So 2000 mg is present in 100 ml. So 1 ml contains 20 mg. Again, 2000 by 100 is 20. For your remembrance, you can remember that 1 ml of solution contains 20 mg of lignocaine. Maximum recommended dose is 4.4 mg of lignocaine with adrenaline, 4.4 mg of lignocaine without adrenaline, plain anesthesia, and maximum dose is 300 mg, and with adrenaline is 7 mg per kg or 500 mg. Sequence of clinical anesthesia is there will be sympathetic block first, then followed by loss of pain sensation, then temperature sensation, then pressure, then touch. At last, there is a loss of motor function. You must remember this sequence as well. It is also asked in exam. The motor function is lost at last. The pain sensation is lost initially. Okay, we'll continue tomorrow.